To go.
All right, awesome. Okay, well, again, welcome. My name is Callie. I'm really excited to be here with you all this morning. We're going to be speaking to behavioral health integration today, which is essentially treating the whole person, and we're talking about that with Sarah Goldman, who is our executive director with the Right Step Houston. May I just add that Sarah has been through so much this week, and she experienced a flood and no power at her facility. So I'm just really grateful that she was able to be here today, and I think we're really going to enjoy this presentation. She's a delight to work with. Sarah, you can
Thank you, Callie.
Yeah.
All right.
Okay, so with promises, we have 9 facilities. We have a few that are just outpatient. We have some that are dedicated to mental health, some that are dual diagnosis. As you know, as you've all heard from Trish, it's a very trauma-informed approach. So we have some of these beautiful photos to show some of our facilities, but just know that also our clinical programming has changed a lot. It's grown a lot, and we're really proud of where it's at. Our mission is to provide attainable, affordable, and accessible mental health and substance abuse treatment with evidence-based clinical integrity. And I think you all can see that through each of these webinars that we host. We have been hosting these webinars monthly since December. We'll be hosting them through the end of the year. And I just think it's a great way to spotlight our great clinical care, our great programming, and it's also a great way to get to know you all in the community that we get to work with regularly as well. So our corporate office is in Nashville, Tennessee. And as you can see, we have programs everywhere in the country, which is really great. So thanks, Sarah. You can hit the next one. We mostly focus on adults. I see a question about youth. It's adults 18 and above. Okay, so during the webinar, as you know, we have some housekeeping things. So the chat box, that's going to be for me. So those of you that are chatting, you can send those comments to me. That's mostly just for if you're having questions about your Zoom or the CE. Just know that if you are here and you registered on Zoom, which you had to do to be here today, you'll be getting credit. So don't worry about messaging me to resend me your email. You don't need to do that. This attendee list, if you are in the Zoom and it says your name in your box, that is like a sign-in sheet. And so I'm getting that, and I will have that at the end. I cannot really check that during the Zoom because we're just in it. So if you have any questions about that, I'll make a note of it. But if you're here and you see your name on your screen, then you're good to go. If you have any questions for Sarah, we're going to do a Q&A at the end. We always have a lot of questions, so we want to make sure we have extra time for that. I will also do some questions in the middle. We'll have a little 5-minute break, and we'll do some questions then. Send the questions for Sarah into the Q&A so we can keep them separate from the chat. And that, again, can be for resources or webinar content, excuse me. Other than that, just enjoy. It's going to be 2 hours, so it's a 2-credit webinar. And I think it's going to be great. So just relax. We're all going to get our C's. Next one, Sarah. Let me get into that a little bit more. So to receive the CE, you have to be here for the full training. If you miss more than 5 minutes, I won't be able to collect your email. And I will send out an email to if you did not meet the time. So today, after the course, I'll send out 2 emails, and that will be one with the list with the evaluation, and then one will be a list that you did not meet the time requirement. If you did not receive an email, just know that you need to check your spam, because it's likely the JOT form is where you're going to get your CE evaluation from, and that can often go into spam if, especially if you're new here and this is your first time joining a webinar with us. If you have any questions about, I think I did get the full time, just let me know and I can double check. Sometimes, say you switch from mobile to desktop, it might collect a phone number and an email, and I can combine those knowing that it's, you're the same person. Also, you cannot be sharing a computer. So again, when you sign into Zoom, that email address is like the sign-in sheet. So if there's 2 people on one computer, I'm only getting 1 email address. So make sure you're each using individual like computers or whatever. Again, after the training, you'll receive an email from JotForm, and that's with your survey. That's with the evaluation. And you'll get that by the end of the day today. Know that I have to go through all of this data and like make sure it's all correct. And I want to make sure that if you have to leave and come back, I add up those times to make sure you meet the requirement. So I need a little bit of time today. By the end of the day, you'll get the evaluation. Again, that is from JotForm, not from me. And once you get that eval, once you fill it out, it automatically sends your certificate right back to you. So again, look for that email from JotForm, and it'll have your certificate right there, which is really nice. If you do not receive that, maybe give it a little bit of time and then get back to me on Monday or Tuesday next week if you have any issues. I won't be checking my email over the weekend, so just know that I will get back to all of your questions on Tuesday. And you have to submit the certificate or the evaluation. You have to submit that by next Friday. That's not a me rule, that's an accreditation rule. It has to be within a week of the webinar. Oh, I know you're all going to be dying for the resources and slides and the recording. That will come out next week on Tuesday, likely. So if you're excited to get those, know that you can take notes today, but you will receive the recording and the key slides next week. Is that everything? Did I cover it all? Oh, next webinar.
Yeah, and Callie, just a note for that, kind of in the end, in the Q&A, if there's any sort of resources, kind of all the information we're going to be going over is pulled from a lot of some very good kind of groups that put out a lot of great information about behavioral health integration. So I will also provide Callie with kind of a best practice resource link that she can also provide to you guys after.
Oh, thanks, Sarah. Can you go back one?
We're jumping ahead. My computer's not listening very well right now.
I'm also seeing some of you all in the chat. If you're looking for your name, if you hover over like where your picture is or would be, as you should see in the bottom left corner. Also, if you're in the chat and it looks like you're chatting to me and you see your name pop up when you chat to me, that means you're good. I will probably not be able to get back to all of your comments and questions at this moment, but I will read them. And if there's anything I need to attend to, then I will. Just know that I probably won't have to get to all of you. Okay, next webinar is going to be next June 28th with Lauren Bentley. She's our clinical operations director at the Ranch, Tennessee. She is wonderful, and I've seen her give this presentation. She has truly a very intentional view on trauma treatment, and I really think that if you've enjoyed our trauma care series earlier this year, like you'll really love this one. She is great. And I will send that link to sign up here whenever I get the moment. I'll put it in the chat for you all to see ahead of time. And in July, we're going to be moving into the operational side of behavioral health. So this will be achieving operational efficiency, critical for the success in behavioral health. Sorry. And Jamise is a delight. And that will be a great session. I will also plug that in the chat, and all of those, again, 2 CEs for each one. It's always free. Okay, Sarah, I think I'm done.
Okay.
Thank you all.
All right. I guess you'll turn it over to me, Callie. Well, thank you guys for joining us ahead of a holiday weekend. So just want to wish everyone a very happy and safe Memorial Day as you approach your weekend. I hope you have some time to have a little fun, have a little rest, and spend some time with your loved ones. We'll get started. I'll tell you a little bit about myself prior to jumping into the content of the information today. My name is Sarah Goldman. I am a licensed clinical social worker and supervisor here in the great state of Texas. I also have my master's in healthcare administration, so I truly kind of have the full continuum of both clinical and operational experience in the behavioral health space. And that has truly become a passion of mine. I started my career, I was thinking about it before this webinar started, in about 2006. So it's almost tapping on 20 years in this space, which I love to see kind of the evolution and the way in which we are making positive change in behavioral health care. And that's truly has become a passion of mine. I love behavioral health with mental health and acute psych, as well as substance use disorders, and truly have a passion for how we deliver care to our people so that we can remove barriers, increase access, and really work towards the holistic approach to health, which is inclusive of both physical health and behavioral health. So that's a little bit about me.
Sarah, can I stop you for 1 second?
Yeah.
Sorry. There's like a black box on your screen. I don't want us to miss anything. So can you just maybe just like unshare your PowerPoint? Yeah, click back into it. No, it's still there. Maybe stop sharing your screen altogether and let's
all right, let's see. Let's see what we can do here.
Yeah.
How,
I'm still seeing it. That's weird.
Is it kind of covering up our content?
I mean, I don't know if it will or not. We could just like, I don't think there's what we could do about it right now, though. I think we'll just have to roll with it, and maybe it'll go away. If it becomes an issue or if it grows, I'll let you know.
Okay, let's hope not. Okay, and so with that, currently, as Callie mentioned, I'm the executive director at the Right Step Houston. And yes, we did have a windstorm come through last Thursday, which was an experience, and we're without power up until, I believe, Tuesday or Wednesday of this week. So it has been a whirlwind, but all is good. In that time, truly, we worked with our patients to engage in their skill management, the trauma-informed care that Trish and Callie have spoken about, and hopefully you guys have seen in this webinar series, and we're good to go. So really excited to be with you all this morning, and I hope you'll take some things away of what behavioral health integration is, why it's important, kind of what it does for our patients and their families. We'll talk a little bit too about kind of the business case for behavioral health integration. And then we'll look at how each of you can evaluate your current practice sites to see where you are in behavioral health integration, and then kind of shoot for a goal of where you would like to be. So with that, some learning objectives for our next, let's see, maybe about an hour and a half together is we're going to look at the historical treatment models for both mental health and substance use disorders. We're going to learn about how eliminating silos within the behavioral health and physical healthcare space can improve patient outcomes. We're going to look at the few models, different models of behavioral health integration that are in practice today, as well as one that is going to be implemented this fall. We're going to see how behavioral health can be a solution for access and work to serve our underserved patient populations, review business case, learn actionable best practices, and take away knowledge of how you can assess your own practice site. So behavioral health from past to present. We will look here that really since the beginning of time, both mental health, mental illness, and substance use disorder has been documented throughout everything. So our Neolithic humans in those times, which is, I think, almost like 10,000 to 2,000 before Common Era, or Stone Age, as we like to call it, they reference mental health as being a possession by demons and actually sought to treat it by boring holes in the skull, thinking that that could cure individuals, which, you know, shout out to the predecessor of what we now know of is a lobotomy, which we'll talk a little bit about as we go on. But also we see this about 5,000 years ago with the ancient Egyptians, recording that they had individuals who were addicted to alcohol and how they would care for those people in private homes, kind of outside of the communal scope. Somewhere between the 5th century and 3rd century BCE, the Greek physician Hippocrates rejected the idea that mental instability was a result of the occult or supernatural causes, and he wrote that imbalances of thinking and behavior were natural occurrences in the body, particularly the brain. So we had a really early adopter there of some early psychiatry. And then we'll look at how the organized and systemic care for those with mental health and substance abuse really kind of came about in the late 1700s across the world, but specifically here in America. So in the 17th century was really early views of mental health care and substance use. And as spoken before, were attributed mainly to supernatural causes or were viewed as kind of a punishment from God. So the conditions like schizophrenia, bipolar, and depression were very misunderstood, often thought to be kind of demonic possession. And sadly, it's estimated that tens of thousands of people who were suffering from mental health issues were killed, whether it was intentionally or accidentally, prior to the 1700s. And when we think in kind of popular culture, we remember things like the Salem witch trials and exorcisms that were occurring with individuals who truly were suffering from mental health issues. So with that, the treatment of how we looked at and took care of those people, and then I use kind of air quotes here, treatment of how we thought of things we could actually do for those people were very, very harsh. So it included bloodletting, purging, and vomiting. And then those that could not be treated were either killed, whether intentionally or accidentally, or kind of cast out from society and truly not wanting to kind of engage with those individuals. In the 18th century, we moved into our kind of age of almshouses and asylums. So again, that treatment, air quotes, continued to be misunderstood and definitely lacked compassion, and really was kind of that out of sight, out of mind mentality for these folks. Where people would kind of be relegated to includes jails, which, fun fact, continues to be the largest mental health provider in the United States today. Private hospitals, which were truly only accessible by wealthy family members that would kind of send individuals off for some respite or rehabilitation. Almshouses were a location that were funded by charitable institutions, often churches or community members, that boarded elderly, impoverished, or the mentally ill. So those areas were really just a boarding and housing situation. They did not provide treatment of any kind. And then we got into what the derogatory term used of a lunatic asylum, which was actually a specialized practice for individuals suffering from mental illness and substance use. However, kind of the name really kind of brings forth kind of thoughts of horrible conditions, overcrowding, neglect, and very inhumane treatment. And unfortunately, kind of that institutionalization model continued into the mid-1900s, believe it or not. All right. But even still, we do have some hope as we move through our time. At the end of the 18th century, a French physician, Philippe Pinel, he argued for a more humane treatment of individuals who had behavioral health concerns. He actually was a zoologist by training, but has now been kind of termed the father of modern psychiatry. So he was kind of revered to be an expert and truly looked at how we can implement compassionate and kind approaches to individuals, and is memorialized by being the individual who unchained people from shackles and straitjackets and really talked with them and on their behalf for rehabilitation and reintegration. So this moral treatment was actually very well adopted in the American mental hospitals in the first half of the 19th century. However, we did experience kind of the issues that we still see today, whether it is a lack of funding or a lack of social support for these individuals. However, a big name in America was Dr. Benjamin Rush, who actually signed the Declaration of Independence. He promoted the adoption of moral treatment principles here in America and actually was a physician, but he limited his practice to individuals suffering from mental illness. So kind of our first psychiatrist here in America. So how things changed, or how the ideas changed, was that in this moral treatment model, they wanted to provide compassionate and human care in a calm and aesthetically pleased setting that included social interaction, emotional support, occupational training, as well as providing individuals with a sense of purpose in their life, whether that be through work or relationships. It really worked to try to treat those individuals and then allow them to reintegrate. So, as I stated, there was initial early adoption of the idea, but moral treatment in practice declined in the late 19th century due to overcrowding, lack of funding, and the emergence of biological theories of mental health, kind of resulting in a regression of the quality care provided. So this photo here is actually one painted by Tony Robert Fleury. We're going to kind of get a look into my high school French abilities, but here this painting depicts Dr. Pinel unshackling women in the Salpêtrière asylum that was located in Paris, France. So this asylum was actually a walled village that housed about 7,000 women who had, whether they were impoverished or had kind of behavioral experiences or diagnosable mental illness. Interestingly enough, the most prevalent diagnosis of women in this asylum was hysteria, which actually we know to be, today, frenzied and frantic behavior. But this was actually a diagnosis that many women received even throughout the 20th century. So in the early 20th century, we saw a rise of psychiatric interventions as well as some very early medication options. We saw that the reliance on institutionalization was lessened, but it was not without cost. So looking at these exploratory models of treatment left many individuals really traumatized, whether that be from emotional trauma as well as physical trauma. So the early kind of adoption of many of these practices were inclusive of the lobotomy, which is pretty much the barbaric practice of putting a metal rod in through the eye socket and up into the brain. And what that did was sever some connections in the prefrontal cortex and hope to then treat some of those behaviors. And what we know is that that did not work and truly was something that just harmed individuals. Also, electroconvulsive shock therapy was completed at that time. We have since learned great things from that early treatment, and now ECT is a highly effective way of treating some of our mental health disorders today. And also hydrotherapy. So this is really an interesting concept of essentially cold plunging these individuals into frigid water that would kind of disrupt the behavior, send them into a hypothermic state, which would calm kind of what we would see externally as behavior. I always have kind of a morbid thought of what are all these people doing with cold plunges today? And it reminds me of the hydrotherapy, but kind of moving from there, I will not be cold plunging anytime soon. And then we move into kind of the Freudian influence on psychoanalysis and talk therapy, and truly moving away from the medical treatment intervention model and into a more psychodynamic approach to therapy. Kind of later after Freud, we had Alfred Adler come behind and kind of bring all of that together in what we know to be now modern talk therapy. We also saw early introduction of psychopharmacology, chloral hydrate and barbiturates were introduced at this time and did lessen and improve symptomology for some individuals. So the middle of the 20th century looked at the deinstitutionalization of individuals with mental health and substance use disorders. And it really shifted mental health treatment from large centralized institutions into community-based settings. So with that, the goal was to reintegrate mental illness and substance use disorders into the community, which would in turn reduce stigma and isolation. So asylums were known, as we stated, to be overcrowded, underfunded, and sites of sometimes abuse and neglect. But then once we kind of moved into the community setting, we found that there was insufficient funding, insufficient resources, as well as kind of a lack of a framework for how we were going to manage these individuals outside of the walls of the asylum or kind of mental health facilities. So what we saw was the closure of the large psychiatric hospitals, and we had some consequences to it that we really are still today dealing with. So many individuals were kind of left in that revolving door, cycling between hospitals, both psychiatric and physical medicine hospitals, jails, and homelessness. So we see this today due to the lack of psychiatric bed availability throughout the United States and massive wait times for beds in these acute settings. And actually, so the behavioral health business published a study in 2023 stating that the number of state hospital beds was actually 10.8 per 100,000 people. And that had actually decreased since 2016 by 8%. And with those beds and those very limited beds being available, actually 52% of them were reserved for forensic treatment. So kind of individuals coming out of our justice system needing rehabilitation in the psychiatric setting. In the 1980s and 1990s, we saw a rise of psychopharmacology as well as the introduction of managed care into the behavioral health space. So this provided significant advancements in research and led to a better understanding of the neurobiological mechanisms that underlie mental health disorders. It also increased and paved the way for development of more targeted and effective medications. So on the market, we saw new medications be introduced, our SSRIs, which is inclusive of Prozac and Paxil, which were much more tolerable medications that treated depression, and our atypical antipsychotics, Chlorozil, Risperdal, Zyprexa, that came in and to replace some of the former antipsychotics and were much kind of easier on the body as well as the patient. We saw lithium and anticonvulsants be introduced as mood stabilizers to treat things like bipolar disorder. We saw second generation antidepressants and anxiolytics, as well as ADHD medications kind of come on scene. We also saw the introduction of managed care, which was intended to improve efficiency and really promote evidence-based practices. However, what we saw in the 80s and 90s was that it actually limited access and really kind of took reimbursement and placed the burden on the provider. One good thing about kind of our late 20th century is we did see the rise of dual diagnosis treatment aimed for individuals with mental health and substance use disorders. All right, so we're going to get into common day and look at what we're doing with the integration of mental health and substance abuse treatment. So with the expansion of mental health parity laws, we saw that this was really the first time that individuals were talking about the need to improve kind of access and evidence-based practices, as well as ensure that individuals who needed help could access help. So the Mental Health Parity and Addiction Equity Act of 2008, and then further expanded through the Affordable Care Act, mandated that insurance plans cover both mental health and substance use as it would any other physical health concern. We also saw that there were advances in understanding the brain and mental health through increased research, which in turn resulted in the increase of evidence-based practices with treatment. There was a focus and shift to a prevention and early intervention model. And as additionally, we looked at how we could reduce stigma and disparities across the mental health space. During this time too, peer support and recovery-oriented services became widespread. And it was really the first time that mental health experts and physical medicine looked at kind of that peer support model and the lived experience and how that could positively impact individuals in recovery and kind of what that could do for both the mental health and substance use space. And that leads us to today. And we are kind of in various forms, regardless of kind of location, different places of based on state and location of what behavioral health integration looks like and what the norm is for your community. So with that, kind of, I think the first place to start is healthcare reform. So healthcare reform is truly any policy implementation or policy change that looks to change how healthcare is delivered here in the United States today. And behavioral health integration is one of those key initiatives for healthcare reform in our country. So what we know is that behavioral health integration is crucial for addressing the comprehensive needs of patients and viewing a patient in their holistic, person-centered approach. So historically, as we've kind of outlined up until this point, mental health, substance use, and physical medicine were siloed and treated independently. And that really led to fragmented care with poor outcomes and higher costs. So behavioral health integration looks at some of these key initiatives in healthcare reform, including expanding access. So do people have access to affordable health insurance and affordable care? Controlling health costs. So this really looks at the rising steadiness of healthcare costs and the strain that it puts on individuals, businesses, families, governments, and working to reduce those costs, whether it be from administrative initiatives or improvement of efficiency, promotion of preventative care, and things of that nature. We also aim to improve the quality of care, which works to look at how are we delivering care? Is it safe? Is it effective? Are we using evidence-based practices? Are we reducing medical errors and implementing kind of communication in which we can share information, and how we can make those improvements? We also want to address health disparities. So looking at how different health outcomes kind of connect with different patient populations, including racial and ethnic minorities, low-income individuals, as well as rural communities. And lastly, we want to promote innovation and efficiency. So looking how all of these things, can they come together to have better care that's more cost effective and highly reliable through health organizations. And that leaves us at behavioral health integration. So before we get started in discussing the ongoing kind of, the meat and potatoes of behavioral health integration, I think it's really important that we have some shared operational definitions of the terms that we will be using. So the Agency of Healthcare Quality and Research Academy provides these key definitions. So I'm going to read them verbatim as they state. Behavioral health is an umbrella term that includes mental health and substance abuse conditions, life stressors and crises, stress-related physical symptoms, and health behaviors. Behavioral health conditions often affect medical illness. And that brings us to integrated behavioral health care, blends care in one setting for medical conditions and related behavioral health factors that affect health and well-being. Integrated behavioral health care, a part of whole person care, is a rapidly emerging shift in the practice of high-quality healthcare. It is a core function of the advanced patient-centered medical home. So with that, there are a lot of common terms that refer to integration, and really they all have the same meaning or a kind of nuanced practice of the same goal. So behavioral health integration is what we will be using, the term we will be using today, but you will also hear that as integrated care, collaborative care, or the primary care behavioral health. And those terms actually come from the models of integration, and we'll get into that a little bit later today. But no matter what you call it, the goal, like I said, is the same. It's better care and health for the entire person. And how to do that is by really looking at how we view the person, how we view physical health, how we view behavioral health, and we really start to acknowledge that there is crossover and shared meaning between the two. So you guys are going to have to bear with me, but I want to start us off with this TED Talk as we look at how behavioral health impacts people and kind of the direction that we're headed.
Shortly before after my 40th birthday, I got in a car and merged onto the highway on the way to work. And suddenly my heart was pounding and my chest was tight and I couldn't breathe. So I pulled off to the side of the road. I made a quick phone call to my wife, Sherry, and left her a brief message that I loved her. And then I called 911. A short time later, the paramedics arrived and they loaded me onto the ambulance. And they put nitroglycerin under my tongue. Nitroglycerin. I thought, wow, they must think I'm dying too. So they loaded me into the ambulance and they took me to the local emergency room. The emergency room doctor there ran a number of tests and she came back and said to me, not really sure what's going on with you, but you don't seem to be in any immediate danger. And so I was discharged from the hospital with a number of referrals for follow-up.
From our home to yours, we're celebrating 25 years.
And so then over the next several weeks, I saw a variety of specialists, received a variety of diagnoses, was started on a variety of medications to treat everything from heart disease to acid reflux. And then, a couple months later, it happened again. But this time I was able to immediately get in to see my longtime doctor. So he sat me down and he said, Tom, look, there is nothing wrong with your heart. What's going on with you? And after a conversation about everything that was going on in my life in that time, he gave me the correct diagnosis of having depression and anxiety. And it was manifesting itself in these terrible anxiety attacks that were making me feel like I was dying. I was really lucky. I'm a mental health professional. I went to my medical provider thinking I had a medical condition, but he saw the larger picture. He saw me as a whole person, and he was able to identify what I was facing were challenges related to my mental and emotional well-being. Unfortunately, this is not the norm in our country. The medical, mental health, and addiction treatment systems are existing in these separate silos, and they're creating this fragmented, difficult to navigate maze, a game of hide and seek in order to find the care that one really needs. This leads to overly narrow diagnoses and at times really bad outcomes for folks, where they end up in emergency rooms, hospital beds, and other institutional settings at the highest cost and likely the least effective treatment in the long run. So to see how this plays out in real life, let's follow the story of Emma, who's in 4th grade. Emma's teacher expresses concerns that she's often absent-minded in the classroom. At times she's falling asleep, and she's making frequent visits to the school nurse with a variety of complaints of aches and pains. Emma takes her to the doctor. Her doctor, after a brief visit, gives her a diagnosis and sends her home, likely without having evaluated or treated all her needs. So how does that play out for Emma? Continued difficulty in the classroom, maybe getting in trouble at school, leading to tension at home, adding to the stress of whatever she's already trying to cope with. That's an example of how the fragmented healthcare system is failing us. But thankfully, this is changing. We're changing the way we're caring for people's mental and emotional well-being, as well as their physical health. We're recognizing that mental health conditions and addictions are genuine health conditions, just like heart disease or diabetes. And this shift is laying the platform to move away from this fragmented system to one that is more integrated and treats the whole person. It's leading to integrated care experiences. So how would this change for Emma? Emma's mom takes her to the doctor. The doctor now realizes, wait a second, there's more going on here than just a physical illness. Emma and her mom are able to go down the hallway and make an appointment with a social worker, one that specializes in working with kids. And that social worker is able to take the time to make a full assessment of all of Emma's needs. Now, the social worker, the doctor, Emma and her mom are able to work together to create a care plan that addresses all those needs. This is an example of how an integrated care approach can be transformational in the lives of those that we serve. There's another innovation I want to share with you. It's the growing recognition in the healthcare system that unless one's basic needs are met, good overall health is very difficult to achieve. We refer to this as the social determinants of health. You may be familiar with Maslow's hierarchy of needs. Developed by Abraham Maslow, this well-accepted theory maintains that unless one's basic needs are met, it's hard to achieve those higher level goals and aspirations in your life. The social determinants of health is a similar theory that maintains that unless one's basic needs are met, good overall health, again, is very difficult to achieve. Simply put, it means that if people don't have a decent, affordable place to live, access to adequate amounts of nutritional food, and other basic needs met, all the best care in the world may not make a difference. What if Emma and her mom are living in a homeless shelter or in their car? What are the medical and behavioral health providers supposed to do about that? I'll tell you what. Increasingly, medical providers and behavioral health providers are partnering together with social service providers in order to develop comprehensive care plans. I mean, now we're really getting it somewhere. Not only having Emma's medical and behavioral health needs met, but also her basic needs, and everybody working together as a team on her behalf. There's a movement going on around the country and here at home where medical providers are increasing their ability to identify and assess the behavioral health needs of those that come to them for care. Also, they're increasing their ability to provide treatment for those behavioral health needs. Coinciding with those changes are changes that are happening in the behavioral health system, where behavioral health providers are increasing their ability to recognize the medical conditions of those that come to them for behavioral health care. And they're increasing their ability to treat those needs, either within their own practices or in partnerships with other medical providers. And so you can begin to see we're trying to aspire to create this no wrong door system in order to get the care that's required for your whole person. It's estimated by the American Psychiatric Association that 1/3 of all adults that are receiving medical care also have a behavioral health condition, such as depression or anxiety. If there are 300 of us here today, that means 100 of us are facing these challenges. 1/3 of the neighbors in your neighborhood, 1/3 of the students in our schools. Additionally, 70% of people who are receiving behavioral health care also have a coinciding medical condition. So this can range from persistent headaches to insomnia to more chronic conditions such as diabetes. And guess what? An integrated care approach will not cost more money. In fact, we think it will not only dramatically improve care, but it will do so at a lower cost. It's estimated that an integrated care approach will save commercial insurers, Medicaid and Medicare, $26 to $48 billion a year just in our country alone. How is this possible? Well, it's possible because when people get all the care they need, when they need it, in the communities in which they live, they're able to avoid those higher cost stays in emergency rooms and hospital beds and other institutional settings, again, likely at the least effective care for them in the long run. We can do so much better for those of us that have heart disease and also suffer from depression. And we can do so much better for those of us that face mental health challenges and need specialized assistance in order to care for conditions such as diabetes. And we sure don't need nitroglycerin to be put under our tongue to know that now is the time to begin to make these changes. We can begin to work together as a community, asking individuals to join in together with us in order to face these issues, not just alone, but together, core issues that we face in our community, such as chronic homelessness, addiction, and mental illness. For example, in the city of Everett, the city is partnering with law enforcement, medical providers, mental health providers, addiction treatment providers, low-income housing providers, and social service providers in order to create comprehensive care plans to help the chronic homeless in our community. All of us bringing our expertise to the table and developing holistic care plans one by one to help these communities rise up off of the streets, get a place to live, get a job, and rejoin us as community members. If you know someone that could benefit from an integrated care approach, would you suggest a resource? Because they do exist. The Ever Clinic, for example, provides behavioral health treatment to those to whom they also provide medical care. And at Compass Health, we are beginning to more and more provide medical care to those that come to us for behavioral health care. We don't have to stay stuck in this system that isolates us from the care that we need. And we can imagine and we can envision what it would begin to look like if integrated whole person care were widely practiced in our communities. People who are frozen in their situation, having their suffering eased, and regaining their lives of emotional richness. Again, the homeless, having all the systems come together and approaching them with a whole person care approach that really allows them the best opportunity possible to get off the streets, get into treatment, get a place to live, and begin that road of recovery to a life that's full of purpose. Parents who are ill and addicted, getting their suffering eased so that they can be the parents that their children need them to be, to move beyond the hopelessness, despair, and anger, and regain the confidence and enthusiasm to raise their kids. I think this is our best shot at attacking the opioid crisis, both across the country and here at home. So many people with opioid addictions have everything going on. They have medical challenges, addiction challenges, mental health challenges, basic need challenges. And unless we come together and bring forward an approach that addresses all those needs, I don't think we're going to make any progress in terms of helping them as an individual or in attacking the problem as a whole. A friend of mine told me about an experience that some have when they're receiving treatment for AIDS. It's called the Lazarus effect. And in the treatment process, they move from being frail skeletons, and then they rise up out of that process, the perfect pictures of health. I've seen this happen at Compass Health. People come to us and they're at the end of their rope. They don't have a home, they're ill, they have mental health challenges, they have addictions, and they don't have any hope. But when we're able to embrace them as a whole person, we give them that best opportunity to raise them up and have that experience to regain lives that are full of recovery and purpose. And so I ask that you would join me in shaping and sharing a new future of health that treats the whole person and gives all of us the best opportunity to live lives that are full of good health and happiness. Thank you. Thank you.
Okay, let's get back to our PowerPoint here. But I just love that video where it really demonstrates the impact on kind of the entire community, both for those suffering from mental health and substance use disorders, as well as our communities. And we're going to talk a little bit about that. And at the end of this, or even now, you might be thinking, oh, this is a no-brainer. This doesn't cost more money. All it takes is collaboration, measured-based tools, and kind of consistency. But I'm going to prove it to you. So give me just a second and we will jump back into our PowerPoint here and go on with this webinar. All right. Okay, so moving on into why behavioral health integration. And so we're going to look at some of the stats here. This TED Talk overviewed that kind of, 30% of people, but actually today, what we know is that almost 40% of all people that are seen in the primary care setting have a diagnosable mental illness, and then 27% of all Americans will suffer from substance use disorders during their lifetime. So I would even venture to say that some of those stats there are pretty low, and these are just reportable stats. So truly what we know is that mental health and substance use disorders have lived in our shamed space for so long that I would really think that these are higher than we're reporting here. And hopefully we can use some of these tools and initiatives to truly help those individuals. We also see that 80% of patients with behavioral health concerns actually are presenting and being diagnosed, whether it's in the emergency room or their primary care clinics. So what that means is this patient population is already kind of presenting to our primary care clinics. So it is our job to recognize the diagnosis and then have a process in place for helping individuals get the care that they need. Approximately 67% of patients with behavioral health disorders are not receiving care, and 68% of individuals with mental disorders have comorbid chronic health conditions, and 29% of those individuals with chronic health conditions also have mental health disorders. So what we know is that individuals with behavioral health diagnosis are often some of our sickest patients in the kind of physical medicine space. And kind of, I think there's some stats I put in here a little bit later, but they actually cost the healthcare landscape more money than any other diagnosis. So that's a really kind of powerful and interesting stat that we'll get to in a little bit. All right, so continuing on, why behavioral health integration? So why is it a worthwhile investment to have behavioral health in our primary care setting? And I'm going to go into this later, but I do just want to take a moment and pause here that when primary care is stated, we also can extend that into any place where kind of the quarterback or is the health home. So for kids, that's going to be our pediatrician offices. For women kind of in their childbearing age, that might be their OB-GYN office. But all of this is applicable to those locations as well. So why is it worthwhile? We will increase our access to behavioral health care. We will improve our health outcomes for patients with mental health and substance use disorders. We will improve health behaviors such as compliance with treatment, physical and behavioral, as well as exercise and diet. We can use data to empower individuals and direct providers to agilely respond to individual needs as they progress. And we can reduce the overall healthcare cost, which really represents opportunity for shared savings, both for healthcare providers as well as patients. So the quadruple aim. So this is kind of an infographic that's put out by the Institute of Healthcare Improvement, and it looks at 4 key areas and initiatives that are kind of paramount in behavioral health integration and why it is so important. So we're looking at improving the patient experience. So improving the experience of care. This is really talking about the quality of care and how it's delivered to patients that improves their satisfaction, their engagement, and overall experience. I like to think of this as how are we modeling healthcare as our Chick-fil-A model? Are we being approached with care that is compassionate, kind? Is it user-friendly? Is it customer-centric? Because we're moving into an area and time that our patients are transitioning. They'll always be patients, but they also are customers and they are consumers of healthcare, and they are demanding better care, which I think we all can think back into our mind of a time where we felt like a number or a patient without a name in a healthcare organization where we truly weren't getting our needs met. So we're looking at improving that experience for patients. We're also looking at improving our population health. So as kind of mentioned in the TED Talk, that individuals without access to our basic needs are going to not be able to maintain their health, and they're certainly not going to be able to access kind of healthcare interventions that will help them. So we need to look at health as the health of an entire community versus the health of an individual. We need to consider family systems when we look at healthcare. And we really need to look at how we are delivering healthcare. Are we delivering healthcare that's based on prevention? Are we promoting healthy behaviors? Are we educating our clients and patients about what health looks like? And are we addressing those social determinants of health, as well as removing health disparities for our underserved patient populations? We also want to bend the cost curve, which is to reduce the cost of healthcare kind of for all of us. So looking at that, we are trying to reduce healthcare spending, maintain and improve quality of care, and looking at increasing our efficiency in the way that we deliver care, reduce the waste that we have through duplication of services. Are we promoting the preventative care because it's much less expensive than our acute care episodes? And are we implementing value-based payment models? So with that, the US, if you didn't know, spends more on healthcare than any other high or moderate earning country. So that's massive. I'm sure we all feel that as our deductibles and our premiums increase for health insurance. But also kind of the sad and scary part is that our country also underperforms in quality in many areas of healthcare. So while we're spending the most money, we're not getting the best product. And that's an area that we definitely can improve on. And then lastly, looking at improved provider satisfaction. With that, are we taking care of the people who are taking care of us? Are the physicians, nurses, social workers, counselors, who are members of the healthcare team? What we hear from them is that they are experiencing the highest level of burnout that they've ever experienced, a lack of work-life balance, and to ensure a sustainable and fulfilling work environment so that they can provide care to us, we must look at how we can help them in their care delivery process. All right. So the integrated care continuum. So integrated care, behavioral health integration, same term. These models occur on a continuum. So it's not a one-stop shop. We have coordination, which coordination is simply kind of working across the healthcare setting to exchange critical pieces of information. So that's with physical medicine and behavioral health for a shared patient experience. So coordination can happen independently of integration. That is if, let's kind of put it in current practice, is if a pediatrician calls a school counselor, or maybe a psychiatrist calls an endocrinologist, if they're seeing kind of parallels in physical health issues with their client that they're treating for a mental health concern. That's coordination, simply having kind of that collaborative approach to care. Then we move into co-location, which is if practices are physically located in the same spot. So having a behavioral health provider located in a primary care or specialty care site with both mental health and substance use. And lastly is kind of, gold standard, but I won't say necessary for all, is integrated care, which we're talking about today. So that goes a step above co-location, which we'll get into more details about both of those things, but it involves the collaborative approach to managing care. So we're not just located in the same spot, we're working together, we're using systems and technology and relationships to improve care for that entire person. All right. So here are the degrees of integration, but before we go into them, I really want to stress something and kind of dispel the thought that this is an all or nothing process. So integration is a continuum, as we stated. So you can have minimal collaboration and coordination. I wouldn't write home about it, but you also can have full collaboration, shared EMRs. You can have kind of co-located services that have the ability to see a dentist, a psychiatrist, a internist, and pick up your meds in the same building. When we think about our current sites, I don't want us to get discouraged if we're not at that multifunctional, multidisciplinary space where we're at. We can bring behavioral health integration into any of our locations by simply tweaking a few things, implementing some screening tools, and truly where the kind of biggest opportunity is creating the environment of collaboration amongst providers. There are ways in which we can become more integrated, and I certainly would stress that that is the way of the future. It is where you're going to get your best outcomes. But even if we don't have the resources or the physical environment, or the support of admin or executives, there are still things we can do. So I do just want to kind of make sure we know that. And then as we look at assessing current practice sites, we'll talk more about that. So we kind of see our three options here: coordinated care, co-located care, and integrated care. And we have these different levels. So this is a nice graphic that really just kind of demonstrates that kind of continuum and the way in which they build upon each other, as well as some of the resources that Callie will send out to you guys will have recommendations based on these levels. So you'll be able to kind of see this. This is a key slide, so you'll get this one in the follow-up, but you can kind of read through this. We won't go over it extensively and see where you're at, but then look at how you might be able to tweak some things or make some changes in your practice. All right, let's talk through our key stakeholders in behavioral health integration. This kind of may seem basic and fundamental, but truly this is looking at the delivery of care in a way that involves individuals who may not feel that they have been involved in the past. And kind of that's our last one, our patients and families. And this speaks to how we collaborate with this entire multidisciplinary and care team to provide best outcomes and best care. So we have our primary care providers. I've also said, let's also not forget our pediatricians and our OB-GYNs in this space, but they are kind of our first point in contact for patients seeking medical care. They provide or should provide a central role for an individual kind of throughout the duration and lifetime of accessing care. When speaking on this, I kind of think of the provider as our quarterback. They're the ones who are calling the plays. They're looking at the entire field and deciding kind of with their team how they're going to approach this care. But that's kind of the role of the provider in this space. Behavioral health specialists, now those are our psychiatrists, or our higher level specialty care provider, our psychologists, our licensed clinical social workers, our counselors, and other mental health support like peer support specialists. And they provide specialized assessment, diagnosis, and treatment for a wide range of behavioral health issues, mental health, and substance use. We also have our integrated care teams. Now, this one might be a little lesser known to you if you're not familiar with behavioral health, but this is inclusive of the provider, inclusive of the behavioral health specialist, but also includes nurses, case managers, other healthcare professionals such as dietitians and nutritionists that work together to see that whole person. We spoke about our healthcare administrators and executives. These are the individuals who are making leadership and strategic decisions for our practice sites, and truly engaging with them in these communications, having an understanding of what behavioral health integration is, why it's important, both from a quality perspective, a cost containment perspective, and a patient experience perspective. I think it's a pretty easy sell there. We also need to acknowledge our payers and our insurers. This is inclusive of our federal government with our Medicaid and Medicare programs. But basically, they play a significant role in supporting and incentivizing behavioral health integration. So through reimbursement mechanisms, billing mechanisms, payment models, they can use value-based care for rewarding providers for providing this type of care, and they do. So these are billable services. They also are incentivized services. So it makes financial sense for kind of a medical clinic or hospital system to engage in this type of care. We also want to look at our community-based organizations. So these are our FQHCs, our mental health clinics, our substance use treatment centers, our community health centers, nonprofit organizations, our clergy and spiritual guides, anyone that touches a person's life that can collaborate and support physical and behavioral health. And one kind of thing of note here, one of the most important pieces of this is those specialty care sites. So we need to have very good relationships with our psychiatric hospitals and with our substance abuse treatment facilities, so that if care becomes too acute, or a higher level is needed, we have those embedded resources at the ready to be able to direct our patients. And then our most important people, our patients and our families. We truly use behavioral health integration to invite patients and families to the table for shared decision-making in healthcare. So we want our patients to feel like the expert in their care. We want them to be seen as essential partners in developing treatment plans and in providing feedback and satisfaction and experiences, so that we can truly drive treatment outcomes that are individualized and from a strengths perspective of that person. All right, moving into how we do this. We do this through measured-based care. So SAMHSA, the Substance Abuse and Mental Health Services Administration, describes measured-based care as an approach to healthcare delivery that emphasizes the use of objective measures to guide treatment decisions and monitor patient progress over time. So measure-based care is a key component to the success of integration and is accomplished through assessment, so regular and standardized mechanisms for getting information about clients and patients, and really looking at that broad perspective, that biopsychosocial. Are we understanding the different domains of care of that person? It's done through goal setting. So those SMART goals, specific, measurable, achievable, relevant, and time-bound process. Are we setting goals that people can achieve, but also are we able to measure them? Treatment planning is developing those individualized treatment plans to meet the needs of patients and help them achieve those goals. Are we monitoring our progress? Or do we have a mechanism in place for feedback? And are we able to adjust when we need to make changes? And then lastly, documentation. Do we have mechanisms in place for sharing assessments, in ways that are HIPAA compliant? Are we communicating effectively amongst our multidisciplinary teams? This is truly essential for ensuring that coordinated care is utilized and we have that shared decision making. So by incorporating those standardized assessments and ongoing measurements, we can optimize quality and effectiveness of integrating behavioral health services. We look at the principles that guide effective integration. Is it person-centered? So this one, while co-location is okay, it's a start, this is where it's not collaboration. So I have seen in some, more challenging integration sites where people say, oh, we're integrated. Like, look, we have the behavioral health specialist, their office is down there. But the question then is, are you guys talking to each other? Do you have warm handoffs in which you identify an issue with a patient and you can readily access that specialist to come in and work immediately with that patient? This is kind of where the magic happens, where we have to get everyone on the same page for team members to learn that they have to work differently than they have in the past. We look at population-based care. So registries. So integrated care utilizes things called registries to keep track of people who might need services. So there are some very sophisticated EMRs, add-ons, softwares that can pull, A1C numbers, BMI numbers, depression and anxiety screening scores through EMRs, and then compile them into a list so the provider, the specialist, the nutritionist know who they're targeting. So if you have an appointment with John Doe, you can pull up, see if they're on the registry, if so, why, and then address those issues, because we know patients and clients, they might not volunteer that information unless they're asked. So that truly ensures that no one falls through the cracks. Like I said, there are some incredible tools out there, but you can do it on Excel too. I have in the past. It is challenging, but we definitely can get there. We also look at our measure-based treatment to target improvement and change. So that, are we actively changing treatments until we get to our clinical goals? So that's that agility that we were speaking about earlier. Are we using treatments that are evidence-based? Are we using our screening tools? Are they valid? Are they reliable for our patient population? Are our interventions appropriate? And do they demonstrate individuality to that person? You guys have heard a lot about measured-based care if you've joined us in the past, with a big shout out to Trish, who has gone over that and loves kind of talking about measured-based care because it is so effective. So that is a huge piece of integration. And then looking at accountable care. Are our providers accountable to the health of their patients, and are they being reimbursed for quality care? And we'll talk a little bit about some of those incentive payments too in a bit. Okay, we're going to take a break in a few minutes, but let's get through kind of some experiences, some real life scenarios where we can truly kind of look at the differences between traditional care models, medical models, as well as integrated behavioral models. So here we have Cecilia. She is a 43-year-old woman who is having insomnia and suffering from anxiety due to work stress and parenting two teenage children. So our traditional model says a provider will support and discuss medication options for Cecilia, and give her some referrals. Not so great. So the real life application, we see Cecilia says she'll talk to a therapist and is provided with a few phone numbers that she can call after the appointment. However, we know, and if you've been in healthcare for some time and in the behavioral health space, is it likely that Cecilia made that phone call, got the appointment, and was able to go? Probably not. She comes back to the provider a few weeks later and states that she has not slept in days and that her appointment is still weeks away. She asks for some sleeping medication and it's provided. However, that does not address the underlying mental health concerns. All right, so we're going to move into our integrated behavioral health model. So how that looks is a little bit different. So after discussing Cecilia's stress and anxiety, a provider will ask the behavioral health consultant to come meet with her immediately in the office. And actually, when this is done really well, that specialist goes into the same consultation or exam room that Cecilia is in with her doctor. And the behavioral health consultant provides 15 minutes of counseling on stress management techniques and schedules another appointment for Cecilia in 3 days. She meets with Cecilia 6 times over the next 2 months and reports to the medical provider that during their last meeting, Cecilia discussed wanting to start some medications. The provider then talks to Cecilia on the phone and prescribes an SSRI to help her manage her symptoms. After prescribing that, the behavioral health consultant continues to meet with Cecilia for support and monitoring as she adjusts to the new medication. So much better, so much different, so much more personalized and supportive when we look at that behavioral health model. All right, we'll go to another example. Here we have Bill. He's a 62-year-old man, recently diagnosed with chronic obstructive pulmonary disease, who wants to stop smoking. So our traditional model is we have a provider who will discuss options, maybe prescribe a smoking cessation medication and a nicotine patch, and give Bill a handout about smoking cessation resources. So, real life application, we have Bill. He's got his prescriptions and a phone number for a tobacco quit line, and he's instructed to follow up with the clinic in 2 months to monitor his progress. Well, he comes back at his next appointment and he's still smoking. When asked why, he states that he didn't like talking about his personal struggles with someone on the quit line because he did not know them. So how can we take this and look at it in an integrated perspective? So it would look different because we would see that after the provider has discussed smoking cessation strategies with Bill, the provider will emphasize the importance of concurrent behavioral health support. That warm handoff will happen where Bill will be introduced to the behavioral health consultant who will schedule weekly check-ins to help Bill stop smoking. When he is seen in the office 2 months later, he has stopped, and he credits the consultant's constant support to his success. All right, guys. Well, why don't we pause here? We're about 10:30 with 30 minutes left in our time together. And let's take about a 5-minute break. During this time, I'm going to get with Callie and review some of the questions that you've been putting in the Q&A, and we'll get back to that in 5 and then review some questions and kind of talk through models of behavioral health. All right, guys. Before we get into the models of behavioral health integration, have some questions that Callie was able to send over that I definitely want to address a few of these as we kind of go into our next section and wrap up here shortly. So question one, does behavioral health integration need to include having all of these services under one roof, or does the collaborative approach between client providers meet criteria for an integrated approach? So the collaboration, while great, would not kind of rise to the foundational level of integration. So you will see kind of one of the first models we'll look at is co-located, and then we'll get into collaborative and integrated models. So kind of short answer, no, unfortunately not. We need kind of that very seamless on-site continuum of care to truly meet the definition of behavioral health integration. But I do want to say shout out to kind of making that collaboration work, because that is the first step to kind of getting there. Next question. How important is it that the justice system, jails, courts, judges, etc., how important is their involvement as it relates to the list of key stakeholders? What, if anything, does the justice system do for the value of integrated care? So great question. I love this one. Yeah, they're a huge resource to us, right? So they would fall under our community partners as we look at managing treatment plans, accountability conversations, you know, always with an ROI, I guess we'll have to say that. But engaging those individuals into care and treatment is definitely going to support our clients as we work together. So while we might not have that on site traditionally as part of our care integration, that's definitely someone that you're going to want to collaborate with to ensure that that whole picture, that holistic approach to care is happening for your client or patient. All right. A note that the treatment model isn't kind of readily available or happening in South Carolina. Or other different counties and cities that this person has worked in, but they think it's a great model. Yeah, so with that, I just say kind of take what you can. We're going to talk through assessing your current practice and see what you can do, what you can advocate for to bring some of this into your care sites. Let's see. Ooh, this is a tough one that I actually am going to talk through, but I'm going to kind of defer this one as we do in our treatment plans, and maybe look to find someone with a little bit more experience in this. So we're asking about genetic testing in the model, which currently it is not included in this model, but looking at for polymorphisms that are repairable and the kind of based on what meds are tolerated by a specific person, and then looking at the biochemical interventions for repairing genetic issues. Super interesting, but not one that is included in the behavioral health integration. And we'll take one more, and then we'll get to the models as we kind of are cutting it close on time here. Where does family violence fall into these modalities? Yeah, so something that kind of is very prevalent amongst kind of some of our underserved or disenfranchised patient populations is looking at DV, domestic abuse, child abuse, elder abuse, and how that impacts the person. So what I would say is that there's nothing specific to integration that kind of looks at that specifically, but I think it would kind of fall into the behavioral health specialist as well as the primary care physician or provider to screen for it, acknowledge it, and ensure safety for that person. So looking at safety planning, understanding the nuances of family involvement when there might be abuse or suspected abuse in that space. So just being really cognizant, I would fall back on kind of what your license and what your education has taught you in how you screen for that. And then certainly it would be a huge thing to have a multidisciplinary conversation about and potentially work into that person's treatment plan. All right, guys, we're going to keep going. Our models of behavioral health integration. My computer is not wanting to listen to me, so give me a minute and let me try to reshare this. We're being slow over here. We must know it's a Friday. Okay. There we go. All right. As we've discussed, and I'm going to breeze through so we can get to our business case and look at assessment here, our co-located model. So this is where we have our health providers working alongside our physical and behavioral health. They both provide services in the same location. However, there isn't that much collaboration or kind of collaboration and interworkings between the two. It's more that they share that same physical space. We then jump to our collaborative care model, which up until probably about 5 years ago was the most widely practiced model of behavioral health integration. This looks at embedding the behavioral health provider that may have been co-located actually into the multidisciplinary team, and truly looks at how we add that collaborative approach to working closely together with the primary care and potentially a consulting psychiatrist to develop care plans and treatment plans for individuals with mental health concerns. So where collaborative care is different than what we'll talk about integrated care next is it's very focused on behavioral health. We don't kind of look at concurrent physical health concerns as part of this model. So moving on to our integrated care approach. So this is kind of, as we look at our steps of integration, this is a higher level of integration where we have co-located services. We have a behavioral health specialist embedded into the multidisciplinary team, but then we're also pulling other people in too. We're looking at the dietitians, the nutritionists, those individuals that are going to help navigate. Nurse navigators is a big one in this space. So it's looking at the seamless integration of behavioral health and physical health in one care site. So some examples I put on here of physical health that might be monitored and tracked is A1C, BMI, smoking cessation, kind of different like compliance to specific treatment modalities that might be treating a chronic health concern in the individual. And then this is also set apart by having some truly shared electronic health records and measured based care outcomes here. So this is a new one, kind of hot off the press, the innovation in behavioral health model. This came out from CMS early, I think back in February. I actually only heard about this model when I was kind of preparing and researching for this presentation today. So this is coming from the Center of Medicare and Medicaid Services and is a key initiative in 2024 for healthcare reform. The model will launch this fall, but generally, what I think is kind of what I'm understanding from this is that it is the integrated model, but we're adding on more community partners. So with that, looking at intervention, so like crisis interventionists, both within the facility as well as mobile teams to go out and ensure that people are being compliant, that they're healthy and well. And in fact, if they're not, being able to meet them kind of in the external environment. It also stresses trauma-informed care, which we love and we'll hear about at our next webinar, as well as increase with technology and app-based kind of psychoeducation to just kind of help educate our clients as they navigate through this space. So those are our models. And now we'll move into our business case and then briefly look at some assessment tools that are available to you to see kind of where you guys are at with your current practice sites. So our current landscape looks at what are our challenges delivering behavioral health right now. So we see fragmentation of our healthcare delivery system, which is what we're trying to solve with integrated care. We're looking at increased comorbidity between mental health and chronic disease, soaring costs due to overutilization and duplication, shortage of psychiatric providers and facilities to provide care, and barriers to reimbursement due to payer requirements. So this impact of untreated mental health and substance use disorders is massive on individuals and communities as a whole. We see increased reliance on social welfare programs, increase in homelessness, increase in costs due to incarceration and judicial proceedings, as well as the social impact that it has on families and communities. We see people not be able to work with decreased earnings and productivity. Actually, the NAMI, National Alliance on Mental Health, estimated that untreated mental health and substance use disorders cost the country $300 billion every year in lost productivity, because that is 50% of people who are, having kind of to leave from work are due to mental health and substance use concerns. A big consultant, Deloitte, put out a publication last year that said if left unaddressed, mental health inequity could lead to $14 trillion in excess costs between now and 2040. So just huge opportunities to look at cost savings, ensure that we stop creeping up as the place that spends the most on healthcare and has the worst returns. We need to look at our market analysis and our competitive edge. So what we're seeing and trending in healthcare and in markets across the country is that now we are demanding integrated care health services. So once this kind of picked up steam, we see the ROI, we see that it's actually very cheap to do as you just are bringing in behavioral health specialists and then working on that relational piece. People are going to start wanting their healthcare to be delivered in this way. So it has been identified as an opportunity for growth and innovation. It will differentiate your site from competitors that offer this service. It is attractive to both patients and providers who are dealing with it because the providers are now supported in providing this healthcare. And it also aligns with value-based care models that have increased payer incentive and billable opportunity. So we talk a little bit more, the return on investment for cost savings of prevention and early intervention. We see that individuals who have early intervention, their use of services decrease by 16% versus individuals who are untreated, their use of services is actually increasing by 12%. We're also seeing reduction in emergency department visits and hospitalizations for people who are cared under an integrated model. They've shown that actually care integration decreases hospitalization rates by 14.2%. And then increased revenue, we've discussed this is billable, this is a bonus potential, as well as positive financial projections for the future. So studies have come out to show that for every dollar we spend on the investment of care integration, we will see $4 return to us 5 years post-intervention. So we are seeing those $4 in return that come through decreased of care utilization. So that's huge. You know, you crunch the numbers, any executive, any administrator, they're gonna love that return. And not to mention, that's the business side, but we know the human side of things and how valuable this is to our clients and our providers. All right, so let's assess. All right, in here, I'm gonna get close to this screen, so excuse me being all up in your business, but looking at the Health Neighborhood Service Delivery Checklist, I love this tool. We will send this out to you in the key slides. What this does, it's a very easy, very kind of brief tool that looks at what do you have in your current practice site, and then there's some recommendations for how to go about either kind of improving what you have or expanding what you have, as well as additional resources that could potentially be brought in. All right, looking at our process, we must do all of these things. So we're going to go through each of these to ensure that our integration process is seamless. So we need to look at our organizational structure. We should evaluate our structure to determine the level of integration that is currently in place between primary care and behavioral health services. So I say this because these questions need to be asked, because what I have seen is that people are doing this, they don't know that they're doing it. So this speaks to kind of that collaborative piece that one of kind of our participants spoke about on the webinar earlier. I guarantee you most providers, whether it's a pediatrician or primary care provider, has a phone a friend in their Rolodex that they contact when they have higher acuity of mental health and substance use patients. They have their referrals, maybe they have a social worker on site, but at some level, like I said, these clients, these patients are already in the care site. Remember, 80% of individuals diagnosed come through our primary care or routine care settings. So they might be doing this. And then it's a question of how do we capitalize on what's already happening? Next, we would consider whether dedicated staff or teams focused on behavioral health integration would be helpful. And yeah, it would be. So looking at beginning conversations about the return on investment, both the business and humanistic business case for these conversations. And then looking at what's your integration goal. You're not going to get there overnight. So what I would suggest is small, achievable kind of tiered approach or a stepped approach to how you want to get where you're going. We need to look through our workflow and our care process. So see how things are going now. What do we do if we identify someone with a behavioral health or substance use need? Where are they going? What referrals? Consider adopting a universal screening tool. This is recommended by almost all payers, and it is billable. So that is billable of itself to screen for things like depression, anxiety, and suicide and substance use. So are we using current screening tools like the PHQ-9, the GAD-7, the SBIRT to be identifying these individuals, as well as tracking use and symptomology over time? And then looking at our coordination and communication process within the practice. Staff training and collaboration. I've talked about this one. It's the ringer and the secret sauce to make this work. But it is to evaluate and train individuals for behavioral health integration so that they know the business case, the personal, the patient-centered benefits that come from this process. Looking at interdisciplinary team building. I think recognizing that this is a new practice and process, and having patience and kindness as we approach this new collaborative approach to care is going to be your determining factor for success. It's not going to happen overnight, both kind of programmatic setup, as well as interpersonal communication and collaboration. So really focusing on how we support these individuals and develop an environment in which they're comfortable collaborating. Looking at the accessibility of behavioral health services in your current practice site, as well as adequate resources in the community. So again, I would always suggest investing in a dedicated and co-located professional if at all possible. And then here's the kicker. Every time I've done this, what I have seen is we embed the behavioral health consultant or clinician, and then we have a wait list that is 10 miles long because our clients want this. They want to have access to a specialist on site in a place that's familiar to them. So contingency plans are important. That's a lesson learned that I have experienced myself in how to work at kind of being able to address this need. We know it's there. It's kind of when you open the hornet's nest and everything comes flying out, you will feel like that. Don't be discouraged. Have some external providers or, the business case to say, hey, look at what we're doing with one. I need 10 more in this care site. And then evaluate your wait times. You're going to want to look at, you don't want to be part of the problem. You don't want wait times to impact the clinician's availability to have that warm handoff like we talked about with our Cecilia and Bill. So if that's the case, then what we do is we need to have appropriate referral processes to handle that until we have enough kind of firepower in the sense of behavioral health consultants to approach the need. We need to use evidence-based practices. So having an implementation plan for appropriate tools as necessary and ensure that our consultants are trained in ways that are going to help and show measured-based progress for our clients. As well as a mechanism for measuring patient experience and satisfaction. So our patients are the expert of their own lives. So in this sense, we need to be able to have a way in which we are tracking their experience and a way in which we are responding and changing our practice to ensure the highest levels of satisfaction and care. And then data. We are nothing if we don't track and collect our data to tell us feedback of how we're doing. So this is truly important as we look at measured-based care, as well as kind of driving those treatment plans for our clients. Our collaboration with community partners, I think we have gone through that extensively. And then here is the capacity assessment for behavioral health integration. We won't need to read through all of this. We will get this sent out to you. It is massive, so don't be overwhelmed when you open it, but it is about a 10-tabbed Excel document where it literally will ask you and guide you through the entire process of assessing your readiness for integration. And it also provides some really good tools for kind of adding additional services here. Future directions, and then we'll wrap up into Q&A. We have just a few minutes left. I am good to stay on if you can. If you cannot, appreciate everyone for their time today. But future directions, look at that IBH model coming this year, so more to come there. Looking at how we're addressing social determinants of health and wraparound services that identify barriers and then work at dismantling them. Really kind of in that tech and digital health tools as a future direction. How can we use tech to improve patient compliance, experience, and ease for both provider and clinician in this space, as well as policy change that will support reimbursement and the sustainability of integration efforts, whether that be through kind of our, our federal payers, Medicare and Medicaid services, as well as our commercial and private payers. All right, and I am going to And there. Let's see here. Callie is feeding me with questions, so let's see where we got. Okay.
If we also don't have time to hit all of these today, we can also just answer them in our recap email next week too, Sarah.
Okay, perfect. All right. Yes, so we have a question about barriers to services within some communities, and how to best address these needs. So there is that formalized tool that we just went over that looks at specific barriers. So that is definitely something I would point you in that direction to kind of look at your current practice site, your current community, and see kind of what issues might need to be addressed with screenings or behavioral health interventions, or kind of increase in resources in those areas. Lastly, let's see. Okay. We have someone kind of bring out the inherent, sometimes distrust that people sometimes experience with outside agencies having too much personal knowledge. And I think kind of with that is really looking at that relationship. So this is where we look at how are we working to have that lifelong relationship with providers. In my setting at the Right Step Houston, what we do is we look at every client who comes in and we look, do they have a primary care doctor? And if they don't, when they leave, they will. Because we stress and want to have that conversation of why that quarterback to care is so important. And what we learn is that when those relationships are formed, trust increases, accountability increases, compliance to care increases. So truly kind of looking at that model of the medical home. And then if that medical home is integrated, even better, because we're going to get our clients to start trusting that all of their needs, regardless of whether they're behavioral, physical, dental, prescriptions, they're all going to be met within the same care space. So I think behavioral health integration as a whole speaks to improving trust in kind of the healthcare space. But I think that trust too starts with recognizing that we have not done it the right way for many years. And it's going to take some rebuild on our part. So I think that takes us to 1101 and kind of a nice sentiment to end on. So really appreciate the time and commitment to the clients that you serve. Take a look. I think integration is right for everyone, but see if it's something that you might be able to work into your practice site a little at a time.
Thanks, Sarah.
All right, guys. Thank you. Take care.